I am really honored to have this opportunity to give a talk to you. And about 6 weeks ago, I got the email from Jerry, and it was a very strange email. He asked me whether I'm interested in giving talk at this meeting. So I'd like to. That was my first response. But his suggestion was, please address effective arterial elastance. That is very unique, maybe unique and also not so generalizable idea. So I wasn't so sure whether I can spend the entire time for that purpose. Then 2 weeks later, he gave me kind of the prototype of this program. And then I looked at my part. It was saying that I'm going to address history of cardiovascular mechanics. And history and EA, well, I can kind of sense. But it may be there are many young people here, so history is not enough. So today I'd like to address maybe half of my talk is somewhat related to history, but half are pretty new. And the title is kind of, I thought about the title, and it's kind of a strange title, but I felt this is comfortable because I'm going to address something pretty new. So let me move to the first slide. So what I'm going to talk today is what is digital twin and basic framework. Then touched upon most of them, but I think even though I taught many students, but still cannot eliminate this particular part, basic framework. Without this, there is no way of understanding cardiovascular mechanics and physiology. After that, then I'll apply the concept to pathophysiological and therapeutic explorations. Now I'm going to address something new in the last part of my talk. So I joined Johns Hopkins 1978. I was just finishing my initial part of my cardiology training. And at that time, the Hopkins was really a special place. And a guy, the Hiro Suga, has been working on endosystolic pressure-volume relationship. He demonstrated that ESPBR is linear, and that slope represents the contractility of the heart. Furthermore, pressure volume area is a measure of cardiac energetics. So it's great. I felt so great. Yet I felt at the same time something is missing. I think that is because I'm from clinical department. Even if I know ESPBR of the heart, how can we translate that information into clinically meaningful parameters? So then I thought that what is the design goal, natural design goal of the cardiovascular system? So that is the way I think when I have something new. This definition is my definition, so maybe everyone has different definition. But in my mind, the cardiovascular system fuels organs and tissues depending upon the demand of the system. And if we can translate the ESPBR business into something like how much you can fuel, just like cardiac output, then I think measuring the ESPBR will have major impact on clinical practice. That was what I thought in 1978, years ago. Many of you may not born yet at that time. Now, digital twin. What is it? It's nothing but just a model, a digital model or mathematical model that links the virtual and real. That's about it. And what I'm showing here is, it is kind of not quite same as Harvey, but very close. Dan and I really spent same time working on the same model, so we have the same model from the beginning. So this is the model we developed at the Kyushu University, also at the National Cardiovascular Center. So we simulate our system and find out what the risk we have, and maybe this is industrial idea, so cost saving, optimization, predictive maintenance sounds great. Like if we can do predictive maintenance in patients, that sounds great. And education, training. But anyway, I need to transform the ESPBR business into cardiac output. It is a difficult story. And the heart is expressed in terms of elastance, pressure, volume, dimension, whereas vascular system is expressed in terms of the pressure flow relationship, resistance or impedance. And it's really like apples and oranges. They never match. So we need to think of some special idea that makes matching possible. So this is what we did. So we kind of tricked our system. That is, we turned resistance into effective arterial elastance. Resistance is not elastance, but as long as we accept this concept, we can make full use of it. So the left panel shows the basic framework. Suppose that you have fixed end-diastolic volume, then changed stroke volume and measure end-systolic pressure. Then you can get second panel showing end-systolic pressure stroke volume relationship. That's okay for left heart, but how about in aortic system? Well, again, suppose that you are sitting in the aorta. If there is no ejection at all, no stroke volume, maybe pressure is 0. But if the stroke volume is 10, you may have the end-systolic pressure comparable to the stroke volume of 10. If you have 20 of stroke volume, then end-systolic pressure may increase. So you can at least have imaginary line which may dictate stroke volume versus end-systolic pressure relationship in the arterial system. So we denoted this slope effective arterial elastance. But the real question is what it is. But at least as long as we can describe arterial system by this EA, we can couple the two systems and get stroke volume and end-systolic pressure, just like shown in the bottom panel. And in the middle panel, I show algebra. But the trick here is I assumed, this is a pretty wild assumption, end-systolic pressure approximate mean arterial pressure. I know that many of you may not agree with that, so we need really extensive validation of this idea. I'll show that later. But anyway, suppose that we can approximate this relationship. Then mean pressure is a product of flow and resistance. And the flow can be transformed into stroke volume divided by one cardiac cycle. So you can get the second equation. And if you look at the second equation, rearranging that equation gives mean flow, or mean pressure or end-systolic pressure is the product of stroke volume times R over T. And R over T has the meaning of EA. Now we wildly couple vascular property to effective arterial elastance so that we can couple the vascular system with the heart. So mathematics is okay, and we can do the same thing on a graph. Very simple. ESPBR is very simple. Then you draw the blue line with the slope of EA, that is R over T or R multiplied by heart rate. So if you have EDV and resistance and endosystolic PV ratio, you can get stroke volume, cardiac output, maybe approximation of pressure volume area, everything you can get. But real question is how to validate this. So as you know, the pressure volume relationship is notoriously difficult to measure unless we have precise measurement of volume and pressure, which is very difficult. So I avoided any possibility of noise, a bias. So we used isolated heart preparation. The heart is isolated, but perfused by different animal. So heart is stable, that's okay. But how we can measure ventricular volume? We put a balloon in the heart and measure the volume in the balloon. And we put the sensor in the balloon so that we can measure left ventricular pressure. So measurement of the left heart is pretty precise and stable. So that part is okay. Then real difficulty comes from how to impose vascular impedance on the isolated heart. And then I thought of mathematical model of the vascular system. It's a set described by a set of differential equations. And feed ventricular pressure to that equation to derive how much flow can be generated for that moment by the left heart. So we can get ejection flow for that moment, and at some point of the cardiac cycle, we can get filling flow for that moment. Then integral of those filling and the ejection gives us the volume signal that drives sub-pump system to this isolated heart. So even though there is no vascular system, the heart feels as if the heart is ejecting vascular impedance. That is how we get this pressure, left ventricular pressure, left ventricular flow, and aortic pressure in the preparation. So I don't think I have time to explain each one of them, so just look at the pressure volume loops. If you look at the top loops, top panel, there are 3 loops. I change the resistance 400%. Largest loop has lowest resistance. If we increase resistance by 4 times, then pressure gets higher and stroke volume gets smaller. So that makes sense. But if you look at the second panel, I'm changing compliance at the same degree. So 400% difference in compliance does not really induce major change in stroke volume. So this is what I was predicted, that when I actually impose this kind of precise loading system on the isolated heart, this is what we get. So I felt comfortable, and maybe our theory, this EA business, is working. But that is still the half of the story, because this is just saying that maybe we are getting something similar to real system response, but quantitatively we haven't compared. So we need to compare whether the predicted stroke volume matches actual stroke volume generated by the system So that's the next step we tried. So if you look at the left panel, this is a comparison between measured stroke volume and predicted stroke volume. As you can see, it is pretty good match. So a single experiment is nothing, so we repeated similar experiment with 7 animals and end up with a similar result. So I felt comfortable that maybe it has some limitation because resistance is not elastance, but with some modulation, we can treat as if the vascular system is elastance. And that framework gives us precise stroke volume. And up to here, preload is defined in terms of EDV, but if I think of the future coupling of the left heart with left heart with venous system, I need to define the pumping function in terms of Frank-Starling's curve, meaning preload needs to be defined by filling pressure. So to do so, I need to introduce ED-PBR to get the algebraic derivation of the Frank-Starling curve. We can do it, and we can get the impedance, we can get Frank-Starling curve analytically. And as you can see, Dan contribute this kind of work a lot. However, this is still not total story. Now we have a Frank-Starling curve expressed by ventricular property and vascular property. That's fine. But in the real world, how the preload to the heart is determined, that is never touched. So unless we reach that level, we can't solve the cardiovascular system. So ventricular preload remains unknown. We need better idea how to deal with veno-ventricular coupling. And then I reviewed Guyton's circulatory equilibrium, which is, all of you know who Guyton is, and he is the guy who developed the idea of circulatory equilibrium. And it sounds great, but if you look at the standard circulatory equilibrium, left heart, right heart, they are not individually visible. And invisible systemic circulation or pulmonary circulation. And particularly, in order to describe left heart failure, Guyton's this figure does not have left atrial pressure. So it has right does not have left atrial pressure. Guyton has right atrial pressure, but left atrial pressure is not shown. So Guyton has some small publication on dealing with pulmonary circulation, but it's not extensive. So we modified Guyton's idea and generalized circulatory equilibrium so that it can cover right atrial pressure as well as left atrial pressure. So intuitively, blue venous return curve will be venous return surface. But it's not proved, so it's just intuitive feeling. So I introduced very general vascular model that is resistance and compliance combination and almost cable type of things. If increase in flow increases result in increase in pressure, it is proportional. It's a linear system. And compliance is pressure dependent. Volume hold by the compliance is pressure dependent. So pretty general. I never define how they distribute. But with this kind of simplification, you can end up with that surface with the bottom line, with the bottom red box, and very simple formula. And we tried this in experiment and proved that the venous return really makes surface. And if you look at right bottom side, there are many lines. That lines is we are seeing the surface tangentially. So if the dots comes on the single line, it means that the surface is very flat. Actually, it is what happened. So we thought that the venous return surface is pretty flat. So after having this, then we have cardiac output curve of the left heart, right heart, and venous return surface. If we have those three equations, we can solve this by computationally. So the intercept between surface and cardiac curve can be numerically derived. So that equation. So again, we need to validate this, whether this model is accurate or not. So what we did was we imposed volume perturbation on the animals and predicted what cardiac output would be, what right atrial pressure would be, what left atrial pressure would be. And as you can see here, the predicted value correlated. Actually, this line of identity is very close. So prediction works pretty well with this model. So we feel comfortable that we are doing reasonable things, and maybe we are in good shape. Now up to here, I'm addressing the basics of the circulation. But from now, I'd like to address the application. And left-hand side is application of digital twins on pathophysiology. Right-hand side is application on therapeutic exploration. I think most of you are interested in therapy rather than physiology, so I'd like to address right-hand side. The red character indicates what I'm going to address from now. So what would be the future medicine? That is what I have been thinking of. And as you can imagine, now car is pretty much self-driving. Planes, airplanes, autopilot, and SpaceX, that's the third picture, again, autopilot system. Right-hand side is USS Enterprise. So that is not real. But in the future, it may be like that. So if you think of our medical system or treatment system, it composes of very nice feedback system. So if we have good digital twin in the blue square, and we get information from patient using sensors, then feed that signal into digital twin. Then digital twin decide what's wrong and propose what has to be done, then send signal to intervention. So that is actually actuated, the actuator, and treat patient. So this cycle can be closed in real medicine. So this is one example. This is not new, yet the concept remains valid. So I'd like to introduce you here. This is autonomous treatment of acute left heart failure. So the system automatically fixes the problem. without human intervention. So the patient is there and plant, and model is in the bottom square. We measure arterial pressure, both atrial pressure and cardiac output in patient. Those variables are measurable in patient, and then send that signal into the digital twin. And digital twin estimated what's wrong in the system, then treat them with pre-learned drug library, using the drug library, then send signal to patient and see what happened. So this is AMI experiment and acute heart failure. So blood pressure dropped from 108 to 91. So, and cardiac output dropped maybe nearly half. Left atrial pressure doubled, more than doubled. Right atrial pressure remained not much different. But power output is 1.43, but it dropped to 0.66. So it is significant left heart failure. And the digital twin identified what's wrong in the system. The top panel is LV function. LV function deteriorated. Second one is vascular resistance. The bottom one is stress blood volume. Those three are identified by the digital twin. Then the digital twin started to fix this one using drugs. In this case, we use catecholamine, dobutamine, nitroprusside, and dextran infusion. So as soon as drug is infused, you can see that the system parameters reach kind of target level, and resistance drop to normal level. And right-hand side is kind of ordinary hemodynamics. It reached to the steady state at normal value in 30 minutes. The entire process is automated. We don't require any human intervention. And what's happened is that if humans do something, it troubles the system. So the best way is untouched, just watch. Maybe similar to autopilot system, the airplane, if there is contradiction between the decision, machine and human, in my understanding, we should trust machine. And this is something like that. Then we are now imposing even more difficult condition, that is the optimization of oxygen consumption, or maybe minimization of oxygen consumption. And this digital twin reduces oxygen consumption by giving inotrope and bradycardia without changing cardiac output, arterial pressure, or left atrial pressure. Those red line shows kind of steady state. But if you look at the top panel, heart rate reduced, but those three hemodynamic parameters remains unchanged. But if you look at the dobutamine, it is changing when we reduce heart rate. So it's counteracting against heart rate change and keeping hemodynamics constant. If you look at the right panel, it shows the difference in oxygen consumption. And well, this is not what I want. By this way, by having bradycardia, heart rate reduced from 130 to 80, so it's a major difference. And oxygen consumption dropped by like a 25%. But hemodynamics remained unchanged at all. So this is just one example, but it can be done with reasonable digital twin system. The last example is mechanical circulatory support. So everyone talked about this unloading. So unloading is good, reduce oxygen consumption, and may contribute to reduced infarction size. But as we discussed today, if we want to keep unloaded condition, it could have the suction problem. So it's nice to have controlled left ventricular pressure. So this is the same slide. This was shown in this morning, and this red line indicates the left ventricular pressure. So the servo system is controlling left ventricular pressure, whatever the value we gave. And right panel shows the correlation between target LV systolic pressure and measured LV systolic pressure. We can control LV systolic pressure, whatever the value we want. And we imposed volume perturbation, and again, ventricular pressure remains unchanged. So as long as we are careful, we can achieve this using digital twin system. But if you look at aortic pressure, if we reduce left ventricular pressure by impeller, it means that the impeller is generating a lot of flow that increases the aortic pressure. So in this particular case, starting from 50 of systolic pressure to 80, it's reasonable, but it is not always the case. So if we combine drug-based treatment with mechanical circulatory support, I think we can do better, much better than this. And also, we are now thinking of combining our system with neuromodulation. We have spent a lot of time on neuromodulation, and its combination is possible. So every element of treatment modality can participate in digital twin model and play their role. So we are thinking of much more complicated, complex system in the future, but as long as we have a good platform, we can enjoy this new modality of treatment. Well, thank you very much for giving me this opportunity to address this interesting story. Thanks a lot.